Okay. Good evening, everybody. Assalamu alaikum jami'an. Good evening to this series of webinars. This is the Thyroid Disorders Academy of 2021. This is our fourth webinar for the year. These webinars are being sponsored by Merck, thankfully, and also sponsored by the Arab Thyroid Association. Welcome all, and thank you for joining. Very wonderful sessions today. I'm joined with Professor Ahmed Makeen, endocrinologist colleague from Sudan, who is also going to be running the question and answers at the end of the session. I'll be presenting three speakers for today, kindly to start producing their presentations, and hopefully we'll have a successful webinar today. So without much delay, I would like to start our first presenter, Dr. Hussein Nwayir. He's from Iraq. Dr. Hussein, he's a consultant endocrinologist, specialized endocrinologist at the Fayha Diabetes Endocrine and Metabolism Center. He's a lecturer of endocrinology and diabetes at the University of Basra College of Medicine. He's an active member of several societies, regional and also international. Dr. Hussein will present to us about thyroid and bone disease. Go ahead, Dr. Hussein. I also want to remind our faculty, please mute your microphones if you're not presenting to avoid any disturbance with the sound. Thank you, Dr. Hussein. The floor is yours.
Thank you. Are my slides clear?
Yes, they are.
Okay. So to start with, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman. Thank you all my colleagues from the Arab board. This is the fourth webinar about thyroid disease. Now we are talking about thyroid and bone disease. There is a little written and there is little written in the guideline about thyroid and bone disease. There is no discrete guideline that should be followed about thyroid and bone disease. However, there is a strong association between thyroid and bone disease. So I will start with the pathogenesis, the link between TSH and thyroid hormone on bone, followed by the effect of hyperthyroidism on bone density, fracture risk in overt hyperthyroidism, mineral metabolism and bone marker in thyroid disease, finally treatment and the prevention of bone disease in patients with hyperthyroidism. By this brief interview and this brief review, I did talk about the effect of hypothyroidism on bone or risk of those patients on differentiated thyroid carcinoma on suppressive thyroxine doses, or the effect of thyroid hormone within the normal range on bone. So we will concentrate on hyperthyroidism at bone. So to start with, the adverse effect of hyperthyroidism on the skeleton were known before the advent of satisfactory treatment for hyperthyroidism. One of the first reports of hyperthyroid bone disease was in 1891, when the famous scientist von Recklinghausen described the worm-eaten appearance of the long bone of a young woman who died from hyperthyroidism. Osteoblasts mediate thyroid hormone stimulation of osteoclastic bone resorption. This is the title of an article that is published by the journal Endocrinology by the Endocrine Society in just 20 years from now. It is talk about the effect of osteoblast and osteoclast when it is incubated with thyroid hormone. If we look here at the graph A, this is the resorption bites per osteoclast. This is the control. This is a different concentration of thyroid hormone. When you look after 48 hours, this is the resorption bite per osteoclast. This is the control. However, with different concentration of thyroxine, there is increased number of bites per osteoclast, and this make the pathogenesis that thyroid hormone affect directly the osteoclast. And also when we look here, this is comparison with the control, the PTH, parathyroid hormone, and different concentration of thyroid hormone, and also for the reception of bites per osteoclast. Here, after 24 hours, then after 48 hours, the thyroid hormone on different concentration reach near to the PTH effect on thyroid hormone. So that thyroid hormone act directly on osteoclast and make the osteoclast more active and cause more bone resorption. Now, this is the dose response for stimulation of bone resorption by T4. This is co-culture of osteoclast and the osteoclast-like line. This is minimum essential medium for 24 hours. We're treated in the absence of T4. We look here at the p-value, which is also significant, and it is usually the highest dose of thyroid hormone leads to the effect of PTH on action on bone. Now, we remain with the Endocrine Society. This is the journal Molecular Endocrinology in 2007. This is the thyroid hormone excess rather than thyrotropin deficiency. The TSH induces osteoporosis in hyperthyroidism. There is speculation whether the suppression of TSH or the thyroid hormone elevation cause the osteoporosis. We look here. This is the mice. This is mice with the TSH absent, and this is the mice P1 with TSH. We look to these pores. This is the this is the bone of the mice. How much it's affected by TSH suppression in comparison to the normal bone mice. Now, when we look after the effect of osteoclast by the TSH and thyroid hormone, now we look to the bone density. There is little scarce about the literature about the bone density with the thyroid effect. This is in the thyroid in 2003. This is the hyperthyroidism, bone mineral and fracture. This is a meta-analysis by Peter Vasegrad and Leif Mosilski. Now, when we look here, this is the untreated patient. Their DEXA scan is usually minus 0.8. However, after 1 year, it reached and it usually go above normal, above baseline after 1 and 4, and reach normal after 5 days from the treatment. And also, this is the score with every year that the patient had with hyperthyroidism, there is more decline with the DEXA scan and bone mineral density. And if we look here, the relationship between age and relative risk of a fracture in patients with hyperthyroidism compared to normal control, the relationship follow up and exponential care, there is increased risk of fracture with the advanced age of patients who have hyperthyroidism, so that the relative risk may reach up to 2.4 in those patients who are 75 and have hyperthyroidism. Now, when we look here, the evaluation of bone mineral density in thyrotoxicosis, this is a well-written article in Singapore Medical Journal in 2006. It's cited many times. Here are the clinical details of 50 patients studied. They took 50 patients, 20 of them are menopausal and 20 of them are premenopausal, and compared the bone mineral density for them. This is the age of the patient, is ranging from 14 to 28. There is females and teen males, and the disease duration for 0.5 to 3. The bone mineral density and this number of patients, there are 4 normal, osteopenia and osteoporosis around 60% of patients. When we look to the serum biochemistry and bone mineral density measurement in patients with thyrotoxicosis before and after 12 months of antithyroid therapy, this is at the 0 month. This is the alkaline phosphatase, and 12 months it is half to the half. This is the lumbar bone mass, it is around 0.7 gram per centimeter. This is after 12 months, there is much more improvement in bone mass. This is the percentage of bone mass improvement, this is 70%, this is 74%. If we measure this at the least significant change, it's usually significant because it's 3% of bone mineral density compared to age-matched control, it is usually also increased. So that treatment of thyrotoxicosis may say correct the basic bone defect that's caused by the thyrotoxicosis. There is also several other studies that show incomplete recovery after treating patients with hyperthyroidism. There is incomplete recovery. These are references of which studies, so that when treating hyperthyroidism, some of the studies talk about that the bone is not recovered completely. Now, when we look here to this article by the European Journal of Technology in 2009, this is hyperthyroid level of TSH correlate with low bone mineral density, the Hunt-2 study. Here, the TSH in relation to bone mineral density in 5,778 women aged more than 40 years without self-reported thyroid disease. This is the bone mineral density at distal site, which is usually the crude difference is minus 22.9. And the adjusted difference is 10.6, which is usual when the TSH is usually suppressed below 0.5. However, this is the reference age when the thyroid hormone is normal. However, also it is a bimodal distribution. Once the TSH is also raised, there is also increased difference at the distal side. However, bone mineral density at the ultra-distal site is usually different. This is 19.6, and this is minus 13 when the TSH above 35. This is the odd ratio for either osteopenia or osteoporosis combined. For osteoporosis is from bone mineral density measured at distal arm or distal forearm. This osteopenia or osteoporosis combined, this is only for the osteoporosis. If we look here, the os ratio, when the TSH is below 0.5, it is usually reached for the osteoporosis 1.35, the os ratio. However, at advanced TSH is usually normal. For the ultra-distal forearm bone mineral density measures, usually the os ratio is 1.415, which usually increases risk of osteoporosis. For the self-reported hypo and hyperthyroidism in relation to the distal and distal forearm bone mineral density in 6,441 women aged more than 40 years. If we look for those who are euthyroid, is usually the reference range. For the those hyperthyroid, the crude difference is minus 17.9 and the adjusted difference is 4.5. And for the hypothyroid, the crude difference is minus 0.2 and the adjusted difference 2.8. So that hyperthyroid is definitely associated with reduced bone mineral density. We continue with the bone density. The histomorphometric studies of iliac wrist bone biopsies show a greater deleterious effect of hypothyroidism on cortical as opposed to trabecular bone. So that the effect of thyroid hormone on thyrotoxicosis is most likely will be affect the distal radius rather than the spine. So we have, if we're going to send the DEXA scan, we should concentrate on the distal radius, like the hyperparathyroidism. In one report, hyperthyroid patient had only a 2.7% reduction in trabecular bone volume, but there is a 40% increase in osteoclast resorption surfaces in the cortical bone, and a 32% increase in cortical bone porosity. There was no change in osteoid volume, so that it will not cause osteomalacia. The three-dimensional construction of the modeling sequence have shown that this change also occurred. In the normal remodeling sequence, osteoclastic resorption and osteoclastic bone formation are synchronized. However, in overt hyperthyroidism, there is delay. The osteoclast resorption is stimulated out of proportion to osteoclastic remineralization, so that the osteoclasts are work faster than the osteoclasts, and this makes gaps in the bone. This is make porous and hollows in the bone and make the bone more fragile and more liable for a fracture. So that bone resorption and formation occur rapidly. The normal cycle duration of approximately 200 days is halved to only 100 days. In addition, more surfaces of resorbing and forming at the same time. Usually we have some part of the bone are resorbing and some are forming. Here are, because of the more recruitment of osteoclasts, there are more surfaces that are resorbing. But with each cycle, there is more bone resorbed than formed, and this is associated with loss of mineralized bone with each remodeling cycle. By contrast, cycle length approximates 700 days in hypothyroid. That is why patients with the hypothyroidism have increased mineralized bone and they have normal DEXA scan. Now we look for the fracture risk. Just we are talking about the BMD. However, this is related to fracture risk or not. When we look here, risk factor for hip fracture in white women, this is a nice study, 25 years from now. This is New England Journal of Medicine. When we look here for this risk factor, when we look here, previous hypothyroidism versus none. If the patient has history of hyperthyroidism, whether treated or not, there is for the base model, it's 1.5. The relative risk of having a fracture, which is usually, and if it is adjusted, it will be 1.7, which is usually comparable if the patient has a previous alcoholism or previous use of anticonvulsant or previous use of steroid. Now, when we look to this original article, low serum thyrotropoin level and duration of suppression as a predictor of major osteoporotic fracture. The more the TSH is suppressed, the more the duration that the TSH remains suppressed, there is an increased risk of fracture. This is the open thyroid register cohort that is published in the Journal of Bone Mineral Research in 2014. When we look here, this is the hip fracture in women, and this is the hip fracture in men. If we look here, then if the patient has normal TSH, 50 to 70 years, while the patient with suppressed TSH, 50 to 75 years, there's definitely increased risk of fracture, hip fracture. And also this will be more separated the Kaplan-Meier curve if the TSH is, if the patient is age above 65 years, so that with advanced age, there's more increases of fracture when the TSH is suppressed. That is why in the guideline, if the patient has subclinical hyperthyroidism, the TSH is suppressed while normal T4 and TSH, and his bone disease, his bone mineral density is low, there is an indication to treat subclinical hyperthyroidism. However, this separation is less clear in men. However, still the p-value is significant because the fracture rate in men is usually less. Now, when we look to the major osteoporotic fracture, is also significant in comparison to the hip fracture. This is the normal TSH 50 to 70. This is the normal TSH in those patients who are elderly, 75 years and more age. Also, the p-value is significant among women. However, in men, the separation is less, and this is usually due to a reduced rate of fracture in men, so that the result needs no number of patients to be evaluated. If we look here to the hip fracture, the proportional hazard ratio, if the patient low TSH, this is the subclinical, the odds hazard ratio is 1.16. The confidence interval is not across one as significant. It's usually significant also for women and for those patients who are 50 to 74 and for those patients who are 75. It is also the same if the patient has overt hyperthyroidism. For major osteoporotic fracture, the p-value is just across one, significant, but not really statistical significant. And that is why for the TSH. However, for subclinical, the p-value is usually significant associated with osteoporosis and increases of fracture. Now, if we estimating the adjusted hazard ratio for fracture as a function of number of 6-month time interval, if the patient has more than 6-month time on TSH was suppressed in which the mean TSH level was below reference, the hip fracture, we look here, the p-value is almost always significant for both the hip fracture and major osteoporotic fracture for women, for men, for subclinical or overt hyperthyroidism. The low TSH based on biochemistry at first contact, post-hook analysis certified by health provider requesting the first TSH assessment. This is the difference between general practice and hospital clinic. However, we have the results are more profound in those who are GB in comparison to hospital clinic. The p-value here is significant, and also most major osteoporotic fracture are significant. Now, the risk of fracture in women with low serum level of thyroid stimulating hormone is also an article. This is the thyroid disease and risk of fracture. This is adjusted and non-adjusted. If we look here, if we normal TSH is usually normal. In the border line low, the TSH from 0.1 to 0.5. This is the hazard ratio is 1.5. However, when the TSH is totally suppressed below 0.1 milliliter per liter, the hazard ratio is increased to 3.4 and 3.6 if it's adjusted. Here, this is in a non-spine fracture. It is usually the number are less, as we said earlier, because the thyroid usually hit the cortical bone mostly at the radius and at the hip. However, we didn't have more comfortable data to talk about at the distal radius. We have data on about hip fracture. Here, also the hazard ratio is 2.2 and 2.3 at non-spinal fracture. Now, when we look to the mineral metabolism and bone marker indices, the increased serum calcium into the circulation due to increased bone resorption had effect of mineral metabolism, which leads to negative calcium balance in hypothyroid patients, so that in the differential diagnosis of hypocalcemia may have see some sort of mild hypocalcemia. Also, hypercalcemia occurs in 8% of patients. However, the increase in serum ionized calcium concentration are more common. The hypercalcemia suppresses the secretion of PTH, leading to hypercalciuria, which protect against hypercalcemia, but lead to negative calcium balance, and that the total calcium stored in our body is low. And this is a potential cause of nephrolithiasis, so that there increases of renal store in patients with hyperthyroidism. Low serum PTH concentration reduce the conversion of 25-hydroxyvitamin D to active vitamin D. Calcitriol. The decline in calcitriol production is compounded by an increase in cholesterol metabolism because we have increased metabolic rate, and that is induced by hyperthyroidism. So it is usually a vicious cycle between hypo and hypercalcemia. Low serum calcium concentration diminish intestinal calcium and phosphorus absorption, resulting in fecal calcium loss, so that we didn't absorb much calcium from our GIT. Malabsorption of calcium may be aggravated by steatorrhea and increased gut motility that is caused by the elevated thyroid hormones. The biochemical marker of bone and mineral metabolism are also affected. The serum concentration of alkaline phosphatase is usually increased double. The osteocalcine, the osteoproteogerine, and fibrolysis growth factor 23 are all increased in overt hyperthyroidism. They may remain high for months. It usually may remain up to 6 months after treatment, presumably due to persistent increase on neoplastic activity. Urine excretion of bone resorption marker, collagen-derived pyridine cross-link, and urinary anti-nucleotide and type 1 collagen is increased and fall to normal after treatment. Now, when we talk about the treatment and the prevention, to start with, this is the influence of hyper and hypothyroidism and the effect of treatment of antithyroid tract and levothyroxine fracture risk. If we treat our patient with antithyroid drugs, carbimazole, methimazole, proparathyroid, and levothyroxine and fracture risk. Here, if we look here at any fracture, hip fracture, Colles fracture, and spine fracture, this is the hypothyroidism and hyperthyroidism. If we look here to the hyperthyroidism, there is an odds ratio of 1.2, at the hip fracture is 1.44, and on Colles 1.414, and on the spine fracture 1.11. So that definitely there is an increased risk of any fracture with hyperthyroidism. If we look here, other use of antithyroid drugs, it is usually returned to normal. The other are returned to normal. So that when we treat our patient, those patients with the hyperthyroid, there is increase of fracture. Once they are treated with the previous history of antithyroid drugs, it's usually reduce the risk of fracture. So that the first time is we treat the status of hyperthyroidism. Second, this is a nice article by in the Journal of Surgery. It is Hungary bone syndrome, a cause of post-operative hypocalcemia after total thyroidectomy in thyrotoxicosis, a prospective study with bone mineral density correlation. Previously, we thought that when you do total thyroidectomy, there is a transient area of hypocalcemia, and this is usually caused by interruption of the blood supply to the parathyroid gland. However, this is usually incorrect. This is maybe a manifestation of Hungary bone status like that one we see in post hypoparathyroidectomy, and this is usually because of the prolonged effect on thyroid hormone on bone, so that there is a transient area of hypocalcemia. This is usually a busy slide, but when we look here for those who are significant p-value, this is a group A, which are usually thyrotoxic and undergo total thyroidectomy. This is group B, which have normal thyroid function and undergo total thyroidectomy. Just when we look here, this is the BMD. It is usually low in those with thyrotoxicosis in comparison to those with the normal thyroid function. This is the BMD in spine. This is usually improved, but it's still below that of patients with normal thyroid function. This is the TSH, which is suppressed in those with thyrotoxic, which is definitely yes, and this is the TSH of normal patient. This is the 6-month serum calcium level. When we look here, after 3 days from the surgery, the calcium level is 1.9, which is usually low. And this is normal in euthyroid patient. So that this is status of hypocalcemia. It is usually mediated by the hyperthyroidism. It looks like the same as the Hungary bone syndrome post-parathyroidectomy. The 72-hour serum phosphorus level, it is usually the same. And the BTH level, it is usually higher. Okay, this is because of the hypocalcemia, and this mediate a state of mild hyperparathyroidism in thyrotoxicosis patient. So that this level, and lastly, this is the serum alkaline phosphatase. It is usually 120 in thyrotoxic patient, and usually at half for those patients with euthyroid. And after 6 months, the serum alkaline phosphatase is due to 102. It is usually still high, while in euthyroid patient is usually the same. If we look here, for those who grow up with thyrotoxic and euthyroid patient, the Hungary bone syndrome only occurs in a thyrotoxic patient. If we look here to compare hypocalcemic episode for those patients with euthyroid in comparison to hyperthyroid, there is statistical difference and the p-value is significant. So that patients who are hyperthyroid and undergo total thyroidectomy, it is definitely will cause them liable for Hungary bone syndrome and hypocalcemia post-operatively. And now, lastly, we will talk about the effect of andronate on bone loss in pre- and postmenopausal hyperthyroid women treated with methimazole. This is the only study that I have found. This is 25 years old. This is the mean and standard deviation of serum osteocalcin level and BMD values on patients taking alendronate while they are hyperthyroid and postmenopausal. This is group A, the control. This is 20 patients in group B. This is 20 patients in group C. This is the baseline osteocalcin level. At 6 months with the treatment with alendronate, there is reduction in the osteocalcin level. At 12 months, there is also reduction in the osteocalcin level with alendronate, together with both doses, the daily dose and weekly dose. Also, there is improvement in the BMD. This is 0.75 and this is 0.79, and the least significant change at 12 months is usually significant treatment with alendronate. And this is with the group C. Now, this is group D and group E and group F. This is a premenopausal patient. This is treatment of premenopausal. The previous group are postmenopausal patients. Also, the osteocalcin are reduced with the treatment with alendronate, and bone mineral density are improved with the use of alendronate in patients with hyperthyroidism. So that if the patient has a fracture and there is osteoporosis, is definitely may have benefited from bisphosphonate, oral bisphosphonate. However, this is off-label use before the age of 50 years because it's not written in the guideline. Now, summary and recommendation. Overt hyperthyroidism is associated with definitely there is accelerated bone remodeling. There is reduced bone mineral density as shown by different studies. There is risk of osteoporosis. There is an increase in the fracture rate, whether spine or non-spine fracture. Hyperthyroidism in all patients and endogenous subclinical hyperthyroidism estrogen deficient postmenopausal women should be treated to reduce the risk of osteoporosis, and this is definitely yes. The bone density change may or may not be reversible with therapy. These changes in bone metabolism are associated with negative calcium balance, hypercalciuria, and rarely hypercalcemia. And by this, we'll end my talk about thyroid and bone disease. Thank you, Mr. Chair.
Thank you so much, Dr. Hussein. That was excellent. Very excellent review about thyroid disorders and bone metabolism. Thank you so much, and also for sticking to the time exactly. Thank you so much. I'm sure we have a great discussion at the end, inshallah. We move on to our second presenter. It's my great pleasure and honor to present Dr. Yusuf Al-Saleh, a dear colleague. He's associate professor at King Saud bin Abdul Aziz University for Health Sciences in Riyadh. He's a graduate from King Saud University, had complete membership with Royal College of Physicians, and also a fellow training in endocrinology, diabetes, and endocrinology, University of California, past president of the Untitled Chapter. Dr. Yusuf will present to us today about hyperparathyroidism. So, the floor is yours, Dr. Yusuf. Go ahead.
Thank you very much, Tamer. Assalamu alaikum. Good evening, everybody. Very glad to be here, and I do thank the Arab Thyroid Association for inviting me to speak. So, a quick review on primary hyperparathyroidism. I don't have any disclosures related to this presentation. This is my outline. The evolution of the primary hyperparathyroidism. We'll focus a little bit on the new entity, which is not new, but relatively new, normocalcemic hyperparathyroidism. I'll mention a few words about our study on primary hyperpara in the kingdom. We'll talk about the diagnosis, the surgical and medical management, and then we'll conclude with a summary. So this disease is a common disorder, and in fact, every endocrine clinic will meet some of these patients. It's a common disorder characterized by incompletely regulated excessive secretion of parathyroid hormone from one or more parathyroid glands. Usually, it's 80% of the patients, it's a single adenoma, single gland. Multiple gland disorder, 15 to 20% of cases, and carcinoma is very rare. I think over the past 25 years or so of my career, I haven't seen except 2 or 3 patients maximum. So it's very rare. Usually multiple gland disorders is more seen in syndromic hyperparathyroidism. Those with multiple endocrine neoplasia type 1, 2A, and 2B. So Clearly, it's defined if hypercalcemia is associated with increased calcium associated with increased or inappropriately normal PTH level. Now, there are three generational phenotypes of primary hyperparathyroidism. 1970 and before that, this was a severe entity, disease of bones, stones, and groans, as had been described, and psychic moons. After 1970, with the advent of the chemical analyzers, which screened the patient even without symptoms, the pattern of the disease has changed. And then after 2000, we now come across a more subtle biochemical signature, namely patient with PTH levels elevated with normal calcium, the entity called normocalcemic hyperparathyroidism. This is ostitis fibrosa cystica. Now, this disorder is now being seen in developed worlds in China, and have been studied comparing the hyperparathyroidism in Beijing, China, compared to New York, United States. And as usual, John Pelizikin, our colleague and friend, actually, is a famous world figure in the field. Was involved in that study and demonstrated the clear difference between the pattern of hyperparathyroidism in developed countries like China compared to developed world like United States. India, for example, is the same, more severe disease, ostitis fibrosa cystica, marked changes in the skull, distal phalanx, and pelvic bones and clavicle. Believe it or not, today we have seen a patient with ostitis fibrosa. Fellows who were with me in the clinic today, we have seen a patient with calcium above 3, PTH 38, 40, and punctate lytic lesions in the skull, which was suspected to have multiple myeloma and sent for hematology workup. Everything was negative. Then they realized that the calcium is elevated, referred to us, and this was the typical ostitis fibrosa cystica. So after 1970, the biochemical analyzers came and diagnosed these patients at an earlier stage without symptoms. This is the biochemical signature of a typical primary hyperparathyroidism in the modern era. So calcium is elevated, phosphorus is normal, alkaline phosphatase a bit of elevation, PTH is clearly elevated, 25 vitamin D usually is low, and actually this is a difference in the presentation of hyperparathyroidism in the Arab world, in our region, compared to the United States. We see more and more severity of vitamin D deficiency, and that reflects on higher level of parathyroid hormone and probably hypercalcemia. 125 is upper range of normal, and urinary calcium is elevated. This is the typical presentation of primary hyperparathyroidism. To address the several types and many questions of hyperparathyroidism, there have been 4 international workshops, 1991, 2002, 2008. That in 2008 was published in 2009, and then the last one, the 4th one, in 2013 in Florence in Italy, and the paper published in 2014 with a group of experts who divided themselves in different groups and come up with the work has been divided between them, and they came up with this beautiful paper on the management of asymptomatic primary hyperparathyroidism. So it talks about presentation, the evaluation, the surgical management, and the medical management of hyperparathyroidism. Let's talk about the presentation. As we mentioned, 3 patterns before 1970, severe disease still seen in developing countries, and now we still see it in our region. After 1970, a disease with primary biochemical and densitometric signatures. After 2000, we come with the entity which is normocalcemic primary hyperparathyroidism. Before diagnosing this entity, let's talk about it a little bit. You have to rule out vitamin D deficiency because secondary hyperpara can be mistaken as primary hyperparathyroidism. Remember, these patients have normal calcium level, just elevated PTH. So to diagnose this entity, vitamin D should be above 30 nanogram, above 75 nanomoles. You have to rule out renal insufficiency because this is another reason for high PTH. Medication which increase PTH, thiazide, diuretics, and lithium. And hypercalciuria. So all of these patients should run through a set of investigations to rule out this other causes which can elevate the PTH with normal calcium. It looks like secondary hyperpara, but in fact it's a primary hyperpara. Everything is normal, so vitamin D is normal, renal function is normal, patient is not on medication, no hypercalciuria, no malabsorption, and then Paget disease and other metabolic disorders which can elevate the PTH are absent. So after ruling all of these entities, then you come with the diagnosis of a normocalcemic primary hyperpara. Belizikian and Shoni Silverberg and her colleagues and their colleagues in New York, in the Columbia, published this paper describing 37 patients. The average age was 58. Women are prevalent, 95%. 78% of these women are postmenopausal, and only 16% are premenopausal, and men 5% only. Now, what's the reason for measurement of PTH? Low bone mineral density. This is the main reason these patients had PTH and calcium measured. Kidney stones, fractures, and others. Now, this is the entity of normocalcemic hyperpara. What is the typical pattern? High PTH, normal calcium, usually in the upper range of normal. PTH is elevated, clearly elevated. Phosphorus, alkaline phosphatase, urinary calcium, urinary N-telopeptide of cross-linked collagen, a marker of pore resorption, is normal. Vitamin D, normal, should be normal. 125 vitamin D is also normal. So everything is normal apart from high parathyroid hormone. This entity is associated with subtle changes in densitometry. Many of these patients can have osteoporosis. So 50% might have osteoporosis at any of the three sites, spine, hip, or radius. And usually they have osteopenic bone collectively. So the 37 patients collectively were osteopenic, but 50% were osteoporotic, looking at the T-score. So here they described a paradox: patient with normocalcemic hyperpara presenting with more symptoms, so subtle densitometric changes, and renal also stone disorder, while patient with primary hyperpara are presenting with less severity of bone changes, bone density changes. The explanation for this is very clear, as they described. This is a selection bias because this is a tertiary care center, a metabolic bone disease unit in Colombia, where patients are referred for a skeletal problem. So the normal evolving theory for hyperparathyroidism, so we think that normocalcemic hyperparathyroidism is the subclinical phase 1 of hyperpara, and then it goes into high calcium with time. Now, what we think newly is that this phase of normocalcemic hyperpara can be either symptomatic or asymptomatic. So it's not purely benign condition. And then with time, they progress to high calcium and the typical hyperparathyroidism. So normocalcemic hyperparathyroidism is a variant of primary hyperpara, and management approach is recommended. What do we do with these patients? Calcium and PTH annually. You don't need to measure these calcium and PTH every month or every 3 months or 6 months, just once a year. They progress very slowly. DEXA scan, again, 6 months, 1 year is not needed. 2 years, 1.5 to 2 years is fine. If they progress with hypercalcemic hyperpara, then we follow the 4th international guidelines for primary hyperparathyroidism. If they have worsening of bone density, or they developed hypercalcemia, kidney stone, or nephrocalcinosis, then you go for surgery for them. Let's talk about the diagnosis of primary hyperpara. High PTH, high calcium. Imaging is not needed for diagnosis. You do the imaging, whether it's an ultrasound, which is now becoming more useful modality than we used to say in the past, that ultrasound for parathyroid is not good. Actually, you can diagnose the disease with ultrasound in good hands. And then everybody knows about system-EB scanning, and then F18 choline, immunofluorescence, new sort of diagnostic techniques which are being investigated and looked up carefully. We don't need to do the scanning except after the biochemical diagnosis. Don't do it to diagnose hyperpara. You do it to locate abnormal parathyroid tissue. Just a few words about our study, as I mentioned in the outline. So what we did in the kingdom is we looked at National Guard Health Affairs institutions in 3 regions: Riyadh, Dammam, Al-Ahsa, and Jeddah. And I do thank my colleagues, Rima Al-Amoudi and Jeddah, Ali Al-Garni in the Eastern Province. In Al-Ahsa, the National Guard healthcare system is a unified system, the same electronic medical record data. So we had this approved from our ethical committee at King Abdullah International Medical Research Center. And we looked at 120 patients in Riyadh, 68 in Dammam, and 55 in Jeddah. The total we looked at is 243 after excluding patient according to the research proposal. We ended up with 205, probably the largest collection of patients with hyperparathyroidism in the Arab world. I'm not going to go across this. It's not meant for presentation. Just a few hours ago, I added these slides. But quickly, 205, the average age is 59. Almost 80% were females. And we looked at the comorbidities. I'm not going to go into the details. We looked at renal complication, how many of them had kidney stones, 15.6%. We looked at skeletal cortical bone. We looked at the densitometry done for these patients. And as has been shown in international studies, cortical bone is more affected. We looked at gastrointestinal, neuromuscular, and psychologic presentation, if there is any in the chart. This was a retrospective study. We looked at the cardiovascular, looking at their visits to the cardiology and any workup for them. And we found that the majority of patients had a single adenoma, usually the right lower, 35%, and then the left upper had more frequency of diagnosis. Now, looking at data from the kingdom, our colleague, Professor Muna Foda at King Saud University, did 2 studies in 1999 and followed by 2007, while our study is now has been accepted for publication. Maybe in the future I'll find a way to or time to present it in more details. So 205, we collected these patients in 3 years. Muna Foda in 2007 collected the data on 44 patients in 7 years, while the first study in 1999 in 16 years in King Khalid University Hospital in Riyadh. Our study is covering 3 regions in the kingdom, so probably we think it's representative for our data. But the shortcoming is that it's retrospective and not a prospective study. So the traditional aspect, let's go to the main topic. Patients need to have skeletal assessment and renal assessment. Remember that hyperparathyroidism in studies has been associated with fractures, vertebral ribs, distal forearm, and overall increment in fractures compared to normal controls. So the up figure is the patient with hyperpara. So it is associated with osteoporosis and risk of fracture. Now, in densitometric studies, I move 2 slides for the sake of time, osteopenia and osteoporosis is common in them. But in fact, in more sort of delicate techniques like high-resolution quantitative CT scan. This is a 3D stack of 100 high-resolution slices, 3 millimeter scan time, and studies carried out and published on the radius and the tibial bones, what happened to them in hyperparathyroidism patient. This is the radius, this is the tibia, this is the total volume, BMD, the cortical BMD. All of these parameters are reduced. So total volume, bone mineral density, the cortical BMD, the trabecular BMD, trabecular bone volume to total volume ratio, trabecular number is reduced, trabecular thickness, and trabecular separation is increased, strength is lower, and the failure load is lowered. And the tibia have been looked at, trabecular BMD and the ratio between bone volume, trabecular volume are both reduced. So this is the control patient, and this is the picture on high resolution quantitative CT scan in primary hyperparathyroid patient. Clear difference with the defect in the microarchitecture of the bone. So this is one of the studies, and looking at these parameters on the high resolution quantitative CT scan, reduction in total BMD, the cortical BMD, cortical thickness, and total volume and trabecular number, trabecular thickness are all reduced on the left side. These are trabecular separation, which is a bad finding, if it's found, is increased. So more separation between trabeculae, weakening the bone, and trabecular separation standard deviation significantly are reduced. The black color is the distal radius, and this is the distal tibia. So probably this technique pick up subtle changes in the bone architecture before it's shown on the scanning. Again, another modality is, so the conundrum in primary hyperpara, lumbar spine BMD is discordant with fracture data. So the fracture at osteopenic range. while high resolution indices are concordant with fracture data. They show clearly microarchitectural changes. So this is lumbar spine and DEXA scanning comparing control to primary hyperpara. They are looking like controls, osteopenia, but their fracture rate is higher, even if they are osteopenic. And this is probably the changes in microarchitecture is seen with more refined techniques like high resolution quantitative CT scan. Trabecular bone score, again, measures the microarchitecture. One way of measuring the architecture, look at this normal bone, and this is TBS score finding. If there are 3 degrees when this technique is done on patient, less than 1.2, that means there is degradation in the microarchitecture. 1.2 to 1.3 partially degraded. More than 1.35 is normal. Look at hyperparathyroidism patient, 1.24, almost at the degraded level. T-score, in this study, 53% had normal T-score finding on bone densitometry, but in TBS, only 27% were normal, and majority, so 72% of the patient either are the degraded TBS reading or partially degraded. So this is a more refined technique to pick up hyperparathyroidism bone disease at an early stage. So moving the field forward with a new hypothesis, primary hyperpara, even when presenting as an asymptomatic disorder, is characterized by compromised cortical and trabecular compartment and increased risk of fracture. Skeletal evaluation in these patients, if you have TBS, you do it. If not, please do vertebral X-ray. They might have morphometric silent vertebral fractures, and you can do this on VFA, vertebral fracture assessment, on the density machine itself if you have the software for it. Renal assessment, the trend for these patients, looking at data between 1965 to 74, 84 to 2000, and then 2010 to 2012. The pattern is less patient with nephrolithiasis and hypercalciuria. Overt skeletal disease is rare now. It used to be common in the old ages, and 80% of the patients are asymptomatic compared to 22.6% in old ages. This is just to document that the evolution of the disease is more subtle and less with nephrocalcinosis and hypercalciuria. So new data and interpretation of old data, just in a summary, skeletal involvement is more evident when primary hyperpara is associated with low GFR. 24 stone analysis, sometimes it helps. So measuring calcium, phosphate, sulfate, uric acid in the urine is predictive of stone if these indices are high. You can detect kidney stones again by X-ray, ultrasound, CT scan. It's the most common complication primary hyperpara, actually more common than bone densitometry changes. So look for them, do X-ray and probably ultrasound, look for silent stones. So you cannot pick these by history. Patients might tell you, I never passed a stone, but if you do a KOB or ultrasound, you find stones, and this is an indication to surgery. So 24 urine calcium is necessary. Stone risk factors and abdominal imaging are the thing that you need to do for every patient with primary hyperpara. Few words about the other manifestation, the cardiovascular, gastrointestinal, and neurocognitive. Frequent complaint, these patients complain of weakness, easy fatigability, depression, intellectual awareness, weariness, and increased sleep requirement. The issue in attribution is that it can present in many other chronic conditions. Many of these patients, they have other associated diseases. They lack specificity, difficult to quantitate, and adequately controlled studies are a challenge. But recent studies have showed inconsistent data. The trend, the general belief, just to summarize this, the disease is associated with psychological manifestations. And these psychological manifestations, many of them, not 100%, not all of them, might get alleviated post-parathyroidectomy. So again, test the well-being, the psychological well-being. If they have any abnormality with that, probably they need interference and surgery, because some studies have showed clear improvement in depression scales. Various life quality scales have improved with post-parathyroidectomy. Cardiovascular risk factor, a lot of studies has been published on the left ventricular function, mass, CVD, fatal and unfatal coronary artery disease, carotid intimal thickness, coronary flow reserve, aortic calcification, compliance of the ventricles and cardiac muscle, and the data are very conflicting relating to the cardiovascular manifestation, as not as clear as the neuropsychological manifestation, which might improve post-parathyroidectomy. But again, if the patient has any cardiac manifestation, this is might warrant looking into the question of surgery. So neurocognitive and cardiovascular system data are not secure enough for decisions on the surgical management. They haven't been put in the guidelines in the 4th International Workshop on the Management of Asymptomatic Hyperpara. They still did not add these as an indication for surgery. In my personal experience, I think if the patient has clear florid symptoms, I would go for parathyroidectomy, because as I said, there are randomized controlled studies which showed probable benefit after parathyroidectomy. Vitamin D deficiency in our region is commonly associated with it. It might play a role or a reason for more and more higher parathyroid hormone in our patients. And remember, the calcium in these patients might not represent the true story, because once you replace the vitamin D, the calcium starts to go up. However, low dose vitamin D replacement can be given to lower the PTH, and it works in some studies. Let's talk about surgical management. You go for surgery for all symptomatic patients, either densitometric nephrocalcinosis are there, reduction in GFR, hypercalciuria, the usual thing that we know about. Asymptomatic, it's a valuable option, particularly in those meeting criteria for surgical intervention, the ones that mentioned in the 4th International Workshop or on the guidelines. Preoperative localization is mandatory adjunct to parathyroid surgery. CT, ultrasound, system EB scanning, preoperative localization is mandatory, but however, as has been said in 1975 by John Dockman, the most important preoperative localization challenge is to locate the parathyroid, a good parathyroid surgeon. Studies have shown more high volume centers are coming with a better result with parathyroidectomy. The surgical approaches are many invasive. It can be a day procedure. Patient come in the morning, leave in the afternoon in a good state, very small incision. And the preoperative localization helps in locating the incision and taking the inappropriate or the hyperfunctioning gland in a much easier fashion. Intraoperative PTH, as you know, with the clamp of the artery, a sample is sent. After the operation, again, PTH drops very quickly. And the criteria for successful surgery, reduction in calcium, many of them just upon return, hours after operation, calcium goes back to normal, PTH is normalized. 50% of drop in measurement if the PTH is measured 0, 5, and 15 minutes following resection. So a drop of 50% following the resection is there in the same day. However, some studies showed that PTH drop might take up to 2 months. And urinary calcium returns to normal if the markers of resorption are elevated, and then all of them return to normal post-parathyroidectomy. What is the improvement in BMD? Very clear. Shoni Silverberg is a person, of course, with Balizican group, did many papers showing the impressive improvement in densitometry after parathyroidectomy. Look at this changes in bone densitometry, progressive gain in density. In some of her papers, she described 12% gain in densitometry after successful parathyroidectomy, and those patients with osteoporosis. So the best treatment for osteoporosis associated with hyperparathyroidism is parathyroidectomy. Improvement in microarchitecture, again, quantitative CT, big difference between the two pictures, before and after surgery, indicating the great improvement after surgery. Few slides before I conclude. If you follow these patients in up to 15 years, again, Belagican group, calcium goes higher and higher. However, PTH tend not to increase over the years. Again, urinary calcium, no much of change. Vitamin D in the state in the 20s remain the same, and 125D is again the same pattern. So without parathyroid surgery, what happens? No progression of hypercalcemia, but actually progression of hypercalcemia, no progression in PTH, but the lumbar spine density comes to drop at lumbar spine, femoral neck, and 1/3 radius with follow-up over 15 years. All of them get reduced with time. So the best thing, look for any indication for surgery and go ahead with it. The pendulum is changing towards more and more surgical approach. So over 15 years follow-up, 37% developed one or more indication for surgery. during 15 years of monitoring hypercalcemia, hypercalciuria, or a BMD drop. As we mentioned, you follow them with these parameters. Medical management, estrogen, raloxifene has been used, not effective. They lower the calcium and PTH, but no effect on bone densitometry. Parathyroid or bisphosphonate, alendronate, and risdronate, they improve the density, but they don't have an effect on calcium and parathyroid hormone levels. Sinacalcet decrease calcium, decrease PTH, but has no effect on bone densitometry. The best approach is combining sinacalcet with bisphosphonate in patients who are osteoporotic, because the combination has been shown to reduce the calcium, decrease PTH, and improve abdominal density. This approach can be taken in those who are not a candidate for surgery. A difference between the third and fourth international workshops guidelines. So the indication for surgery increment in serum calcium 1 milligram per deciliter, 0.25 nanomole above normal, changes in DEXA scan. But again, in the fourth, they add vertebral fractures by X-ray or vertebral fracture assessment. So osteoporosis or fractures, indication for surgery. Renal, they said in the third, not 24 hours is not indicated, but now 24-hour calcium is recommended. Less than 400 plus other urinary biochemical indices of increased stone risk. As we mentioned, stone urine collection for parameters which indicate that this patient is liable to develop stone can be helpful. Creatinine reduction less than 60. All of these as indication of surgery. The age remains the same. Below 50 years of age, go for surgery. Follow-up annual calcium, DEXA scan 1 or 2 years, CT or VFA if clinically indicated, creatinine clearance annually, stone risk profile if clinically indicated, patient with suspicion of stones, abdominal imaging, X-ray, CT or ultrasound. They said if clinically indicated, I do it routinely to see if there is any nephrocalcinosis and refer the patient to surgery. As I mentioned, the pendulum is shifting to more and more surgical approach. Remember, many of them, they get worsening of their hypercalcemia, worsening of their densitometry parameters, hypercalciuria, and nephrocalcinosis again is a risk. So younger patients do not hesitate to send them for surgery. I tend to send even 60 years, up to 60 years of age to surgery, because we've faced several patients who come to the emergency room if we left them without surgery with hypercalcemic crisis and get admitted for surgery. But elder patients, probably, if they have no indication for surgery, just you need to follow them up. So in summary, hyperparathyroidism is a common disorder in every endocrine clinic. Today we have seen almost 3 patients. Those with fellows who are watching this have witnessed this in today's clinic in the afternoon. Pattern is changing over the years. Normocalcemic hypopara is becoming more and more common. We might come at one stage of normal PTH, normal calcium, and somebody does a scan for a reason and there is a parathyroid adenoma. Maybe this is the fourth pattern that we might see in the future with some changes in densitometry and renal guidelines. I don't know, but speculating. The 2000 international guidelines form basis of diagnosis, treatment, and follow-up. We still need prospective studies in the region. I think our study served as a basis for better studies. It's a retrospective study. We need prospective studies. So you diagnose the patient, you do all the workup, and you follow them up if they are not operated to look at the pattern. I think in our region, we are seeing more aggressive forms still. Still, we see patients with advanced disease. And we hope that the understanding and more workup with the help of the Arab Thyroid Association can help in getting some sort of collaboration between us to come up with bigger studies and more prospective trials. Thank you very much for your attention.
Thank you so much, Dr. Youssef. Excellent review as usual for the topic. Very well done. Thank you so much. And also, again, sticking for the time. Excellent job. Thank you, Dr. Youssef.
Thank you.
So we move on to our third presenter for the day. Also great pleasure to present our next speaker. Our next speaker, Dr. Mohammed Al-Falasi. He's a consultant physician in otolaryngology and head of the head and neck surgery at the Mediclinic hospitals. He obtained his French board in otolaryngology at the University of Montpellier and also holds a fellowship in the head and neck oncology and microvascular lab at the University of Montreal from Canada. Dr. Mohammed will speak to us today about updates in thyroid and parathyroid surgery, concentrating mainly on differentiated thyroid cancer. And I'm sure he's happy to answer your questions also about parathyroid disease. Floor is yours, Dr. Mohammed.
Thank you very much. It's a pleasure to be with you today. Thanks for the kind invitation. With such esteemed group, it's a big pleasure and honor. I don't know if my screen is clear.
All clear, Dr. Mohammed, yes.
Okay, so I'll go ahead. So I'm going to speak more on differentiated thyroid cancer, updates in surgery, and I don't know. Okay, this is Mohammed bin Rashid University, where part of my teaching and education goes, and I have no conflict of interest. So the main things that I'd like to speak about in differentiated thyroid cancer is the management of differentiated thyroid cancer according to updated guidelines. So I like labeling differentiated thyroid cancer as the good, which is, alhamdulillah, 95% of the cases we're doing, the bad, which is lower group, and the ugly, which rarely we see. In 2015, American Thyroid Association Management Guidelines have published a very detailed report and guidelines, which are still valid till today in 2022. And since only 5 to 10% of all nodules are malignant, how do you find the small number of cancer in the vast sea of benign nodules? As a surgeon, we have to stratify our patients and to choose who to operate on, and not any patient with a nodule, we just put him under the knife. So differentiated thyroid cancer, which includes mainly in 90% of the cases are papillary and follicular cancer, they comprise of the vast majority of tumors. So we see that the trend is going up in diagnosis, and the incidence is increasing of finding more nodules. But on the other hand, the mortality of thyroid cancer still stays the same. So I'm just in love with this table, because this table helped us a lot to differentiate and know who to treat more aggressively in our patient, and it made our MDT discussion much more easier. Just I'd like to elaborate that the multifocality of papillary thyroid cancer is stratified as low risk, but still here we consider multifocal in our center as a more aggressive disease. So we might stage it up to intermediate risk, and we give radioactive iodine for that, seeing that it is more aggressive. So the TNM have changed recently, as all our esteemed speakers knows, and just to elaborate, the cutoff age increased from 45 to 55. The criteria for diagnosis extrathyroidal extension were changed from preoperative finding to gross finding. Minor extrathyroidal extension was removed from T3. T3A, a new category, indicates a tumor more than 4 centimeters. T3B indicates a tumor of any size with gross extrathyroidal extension invading the strap muscle. T4A indicates gross extrathyroidal extension invading the subcutaneous soft tissue, larynx, trachea, esophagus, and the nerve. Patient having upper mediastinal lymph nodes are classified as having N1A. And in the 8th edition, findings obtained up to 4 months after surgery are included in the TNM staging system. So as you all know, that the staging system have changed recently. So how do we predict the outcomes of papillary thyroid cancer? In this beautiful study, it demonstrates how can we tell the prognosis after diagnosis thyroid cancer. And there are many ways of identifying that. One of them is the Macy's system. It's a study that was published showing that given a higher Macy's score gives a less survival rate. So it was related to age, tumor size, and very importantly, if there was a complete resection of the tumor and if it was locally invasive and if there is a distant metastasis. So in the 20-year cause-specific survival rates for the patients in Macy's, less than 6, 6 to 6.99, 7 to 7.99, and 8 plus, as you can see here, that the survival rate decreased from 99% to 24%. So age, resection, and locally invasive, and if there is distant metastasis. So in another study, managing patients with papillary thyroid carcinoma, insight gained from the Mayo Clinic group treating 2,512 patients showed that Macy's group that were 6 plus had a higher mortality and a higher risk of death, which reached into the 60% of survival rate. So for patients of Macy's less than 6, that was a very good outcome patients, while Macy's 6 plus had an outcome. So I'll pass this slide. It's as I mentioned earlier, differentiating between the low risk, the intermediate risk, and the high risk group. So elaborating more in differentiated thyroid cancer, we have an excellent response if the imaging is negative post-surgery, and the thyroid globulin, which is less than 1. Indeterminate response, 15 to 20% recurrence rate if the TG levels are higher. And another way of stratifying our patients after surgery is by biochemical response. So if there is biochemical incomplete response, there is a 20% risk for thyroglobulin concentration higher than 1 or higher than 10 ng per ml. The most important thing is the resection and how much is resected. For structural incomplete response, there is a higher risk of recurrence, which goes up to 50 and 85%. So surgery per se is the most important criteria, giving the resection rate that with free margin, raising the prognosis up to 98%. So the good, I call it the thyroid micro-PTC, where you have a nodule less than 1 centimeter. This gives an excellent response and a survival rate which is higher than 99%. So a study of 900 cases observed in a 60-year period, none of the 892 patients with initial complete tumor resection developed metastasis during 20 postoperative years. And there was a higher recurrence rate were seen in the multifocal tumor and node-positive patients. This is where I spoke earlier about the multifocality, which was categorized earlier as a low risk. But multiple studies showed that multifocality, even if there was a tiny tumor, we in our institute, we are a little bit more aggressive with that. So surgery for differentiated thyroid cancer. So a little bit of anatomy. This is the cricoid, the sternal notch, and the cricoid, and the thyroid cartilage. So the thyroid lies in between. We identify the thyroid with marking the incision. We expose the thyroid and the carotid artery on the lateral aspect. We expose the recurrent laryngeal nerve here, and we can see the parathyroid gland here. We dissect off the parathyroid, leaving the parathyroid with the vessel and retracting the thyroid gland medially, exposing the recurrent laryngeal nerve, the parathyroid gland, and dissecting it off slowly. There are different ways that the recurrent laryngeal nerve can present. It could be bifurcated, so 2 branches of the recurrent laryngeal nerve. It can be trifurcated, 3 branches. It could be a non-recurrent coming from the side. So the doctor experience is very important to save the recurrent laryngeal nerve. Following that, exposure of the gland, cutting it off the Berry's ligament, exposure of the thyroid nodule, exteriorizing the lobe, and final closure. It's a simple procedure in experienced hand. Verification of homeostasis, and usually the patient stays only for 1 night. So the bad. We spoke about the good micronodule. The bad, I would say, a patient who at 38 years old, post-thyroidectomy, multifocal, the tumor mass is 3.7 centimeter. The carcinoma is very close to the margins. Distance is less than 0.01. There is lymphatic invasion. The total number of lymph nodes that were removed from this patient are 40, and 21 were positive. This is a bad pathology. I think the patient will be apted for radioactive iodine and discussion with our colleagues. So incidence of multifocality and potential prognostic impact so multifocality gives an indication that the tumor is more aggressive, and we treat the patient after discussion in the tumor board. So another study showing the relation of multifocality on the recurrence rate and the prognosis of papillary thyroid carcinoma. So overall survival of papillary thyroid carcinoma in a single institute by the equipe of Maya. So the most important prognostic value was patient age. So patient above 55 years old, I tend to be more aggressive. Patient less than 15 years old, I tend to be more aggressive. Tumor size is very important as well. Patients with tumor size more than 3 centimeters, I would tend to go for total thyroidectomy. Although in the guidelines, it's mentioned in one clause that tumors up to 4 centimeters, we can go for a lobectomy. But in our institute, our cutoff is 1 centimeter. Sometimes in few cases, we go up to 2 centimeters, but we never go above 2 centimeters for a lobectomy. We still don't feel relaxed to go for lobectomy for a tumor that is more than 2 centimeters. So where does the age comes from? The age greater than 60 years, it comes from a study done by Kaufman, and it shows that patients who are 60 years old and more are more likely to be male, present with tumor size more than 5 centimeters, and more likely to have metastatic disease. So the survival rate and the probability, the disease-free survival at 10 years decreases with age. So in conclusion of that study, that age more than 60 years old was an independent predictor of survival and recurrence that affected the current staging in this guideline. So another important prognostic impact is if there is minimal extrathyroidal extension, or in this study, it shows that minimal extrathyroidal extension is significantly higher compared with those with no extrathyroidal extension. So this is another prognostic impact that puts the category of patients from good to bad. So in this study, we indicate that minimal extrathyroidal extension was similar to maximal extrathyroidal extension. And it was also a risk factor for poor prognosis in patients with papillary thyroid cancer due to a higher rate of recurrence and decreased disease-free survival. So neck dissection, we never do prophylactic neck dissection. In regards to lymph node, we are very much dependent on ultrasound. And in this study, where groups of patients were seen between 1992 and 1996, and another group of patients in 1997 to 2007, and another group of patients between 2007 and 2012. So what it shows that with time, the ultrasound specificity and the experience of radiologists to identify suspicious lymph nodes are becoming more and more sophisticated. So if I have a patient with a negative ultrasonographic lymph reactional lymph nodes or benign looking lymph nodes, I would not touch the lymph nodes. But if the radiologist mentions that there are suspicious lymph nodes on the lateral neck, I would go for a biopsy of the lymph node on the lateral neck, because this will change my my treatment plan from a total thyroidectomy, if it was positive, to a lateral neck dissection. This will change the scar. So this will change the idea how to treat the thyroid. Say if you have a thyroid nodule which is very small on one side and you have a suspicious lymph node, you were going for lobectomy. But if the lymph node is positive, then you're going to go for a total thyroidectomy and lymph node clearance of the central and the lateral. So the tumor size, don't fall in the trap that if the tumor is less than 1 centimeter, some micro nodules can have metastasis to the lateral neck. So proper evaluation of the lateral side of both necks. I mean, any patient with a thyroid, suspicious of thyroid cancer, we have to make sure that the ultrasonographer, the radiologist, have done a complete, thorough neck mapping. Sorry, I went out of this study, which the average number of harvested lymph node, lateral lymph nodes, were 21.4 in group 1, 13.9 in group 2, and 14.1 in group 3. And the distance recurrence-free survival of the three groups were different. It was significant better in group 2 and group 3, where the ultrasound electric linear probes were introduced, and it was more used in diagnosing thyroid cancer. And we can see here the Kaplan-Meier curve of the lymph node recurrence-free survival of patients in group 1, 2, and 3. So neck dissection only for positive ultrasound, plus minus FNA accordingly. Metastatic lymph node characterized as predictors of recurrence and persistence in the neck and distant metastasis differentiated thyroid cancer. Honestly speaking, in this study of adult patient diagnosed with differentiated thyroid cancer in 2 referrals, the goal is not to miss lymph nodes in the lateral neck. In those 2 groups, actually, they found out the number of metastatic lymph nodes and the size of the lymph node and the presence of the lymph node in the lateral or central compartment and extranodal extension are the most important factors in recurrence and persistence of disease. with all indicated indications and p-value less than 0.01. Risk factors for distant metastasis is vascular invasion of the primary tumor, and if there was an N1B lymph node metastasis. The prognostic significance of nodal metastasis from papillary thyroid carcinoma can be stratified based on the size and the number of metastatic lymph nodes, and if there was extranodal extension. So those three factors, the size of the lymph node, the number of the lymph nodes, and if there is extranodal extension, we have to be a little bit more aggressive and put the patient in the group of the bad rather than the good. Another study, the prognosis of patients with papillary thyroid carcinoma having clinically apparent metastasis to the lateral compartment. In this study, it investigated difference in the prognosis of 621 N1B patients based on these features and compared those prognoses with 4,297 patients without metastasis and 125 patients with clinically apparent nodal metastasis. Again, lymph nodes that are larger than 3 centimeters, extranodal extension, and more than 5 lymph nodes puts the patient in the bucket of the high risk group. So moving from the good, the bad, the ugly. The ugly is when you have a patient with laryngeal invasion or a patient with vascular invasion. So I have this patient who's 42 years old, operated in a private hospital, and he had an incomplete surgery. So part of the tumor was left. Eventually, there was a recurrence rate that I mentioned earlier, 55% to 85%. He came to me with a palpable hard mass. If you can see here, this is the carotid artery. This is the carotid artery, and the tumor was invading around the carotid artery. So this patient, we first did an angiography. We blocked the carotid artery to see if there will be perfusion from the other side radiologically, and we blocked the artery to see if he can move his half of his body. So we do a neuro assessment, and the patient had contralateral perfusion in case we had to block the artery in the surgery. So the total number of, we did the surgery, removed the tumor, the total number of lymph nodes were removed there, 23, 12 were positive. There was an extranodal extension. That's a bad criteria. There was tumor capsule invasion, angio invasion, and lymphatic invasion. The staging was T4A and 1B. This is the surgery. We did the sternotomy. As you see here, this is the carotid artery. And we removed the tumor that was engulfing the carotid artery. If you see here, this is a beautiful demonstration of the vagus nerve going around the aortic innominate carotid artery, and it is going to the recurrent laryngeal nerve. So we dissected the whole tumor. This patient I operated on 6 years ago. He died last year. So he survived 5 years after the surgery. He did a very bad metastasis 4 years after, where he had radiotherapy, and Allah yarhamah wa yaghfir lah, our patient died last year. So this is a bad cancer. We cannot say that all differentiated thyroid cancer is good, and we have to be really kind and not treat it and wait for this. We still have to treat the disease. And we have to put in at the back of our heads that there are patients that could present in a very bad status. And if they had an incomplete resection, this can turn out to be a nightmare in the future. So the management of early stage and late stage thyroid cancer, as well as approaches to thyroid nodule, has changed markedly in the past decades. And evidence-based personalized approach is the best approach to treat thyroid cancer, and discussion with colleagues. This is my team. Thank you very much.
Okay, thank you very much. Thanks to all our speakers. And I think that's all we have for today. Let me first take the opportunity to thank the Arab Endocrines, the Thyroid Association, for organizing these activities. Let me thank Aspire Group for organizing it and coordinating it, and the Merck Company for sponsoring. Thanks to the speakers. Indeed, we have really enjoyed great talks, very intriguing and indeed very entertaining. Let me specifically thank Dr. Yusuf for the work they did in Riyadh, which is very gratifying, and I'm glad we get from the Arab world such work that can be published worldwide. Great work. Now we are going to open the platform for questions and queries. The coordinators from Aspire are going to inform me with the queries and questions from the audience, and I'll then broadcast the questions for you. And maybe I'll have the duty of deciding who is the speaker who is likely to answer the questions. So can I call for the Aspire group to give us the questions that are available so far? Okay, thank you very much indeed. We seem to have quite a good number. Right.
Can I make a remark, please?
Please do.
Thank you very much, Dr. Yusuf, for a beautiful presentation. Actually, recently I wanted to speak about parathyroid surgery as well, but the time is really limited. But quite recently, for patients that are non-localized by ultrasound, parathyroid adenoma, and non-localized by scintigraphy, I recently had an excellent way of localizing a parathyroid adenomas using PET choline CT. And for I operated maybe at least on 10 patients in the past few months, where they were non-localized by ultrasound and scintigraphy, and they were localized by PET choline, and it was very sensitive and specific. So what's your experience with PET choline?
Thank you, Dr. Mohammed. Yes, absolutely true. We have this procedure available in National Guard, Abdul Aziz Medical City in Riyadh. And we patients who have negative scan on system EB, we send them for F18 choline PET scanning. Excellent result. And in studies on the modality, the sensitivity and specificity was really beautiful. So, but we reserve it because of the cost as a second line. Majority of the patients are diagnosed with system EB. So we reserve it for patients who are negative on system EB scanning, and we send them for F18 choline. Also, 11 choline has been studied in some centers. Again, excellent result. Yes, I agree with you. This modality is quite sensitive and specific. High sensitivity and specificity.
So I was questioning if the cost is could be justified instead of doing the ultrasound and the scintigraphy. Would a PET choline cost less than both two tests?
Actually, in our centers, we tend not to do much of ultrasounds. although the literature says it can be excellent in good hands. We go immediately to the system EB scanning, and as I mentioned, as has been shown also in our study in the 205 patients, it's quite satisfactory and picks majority of the patients. National Guard Riyadh, as I mentioned, we go for F18 choline if the system EB is negative. So I think our radiologists tend not to agree with us on doing PET immediately. So they prefer doing system EB first, and then if negative, then we'll go for F18 choline. I think we need to rediscuss that with them and think really seriously of going for it as the first modality. Ultrasound, I'm not in favor to do it frequently. We just go for the system EB in the first instance.
Honestly speaking, for me, my practice when I go to surgery is localizing it with two tests better than one, because scintigraphy is not always specific and sensitive. So I would regret if I go in and it is localized by scintigraphy and I couldn't find it. So I tend to do the ultrasound and scintigraphy, two tests, to make sure that this is the parathyroid. This is my practice.
Well taken point.
Okay, thank you, Dr. Muhammad. Let us give chance for the questions coming to us from the audience. Right, I think I have a few questions here. Let me go for the chat. Sorry. Right. First question is, do the osteoporosis and fracture risk the same whether the hyperthyroid state is due to a nodule, toxic nodule, Graves' disease, thyroxine suppressive therapy? Question, I think, goes for Dr. Yusuf. Dr. Yusuf, please. No, this is parathyroid. Yes, it can be Dr. Yusuf, please.
Dr. Hussein.
Dr. Hussein.
Yes.
Dr. Hussein, right, Dr. Hussein from Iraq.
When we look for the literature, it is usually they did differentiate the cause, whether it's nodule, Graves' disease, or multinodular goiter. They usually focus on the level of TSH and the level of free thyroid hormone. So there is no studies that look on the cause. This is the first part of the question. For the second part of the question, thyroxine suppressive therapy, we usually give it for those patients with the differentiated thyroid carcinoma, high-risk patient, to maintain their TSH below 0.1, and it's usual for a long period of time. Some societies advocate the use of DEXA scan before, because we maintain that level for around 2 years. So definitely it is yes. However, there is no head-to-head trial comparing the two. Both of them associated with osteoporosis.
Thank you very much. Second question also goes for Professor Hussein Anouir. With the new emerging data about beta blockers preventive benefit to osteoporosis, can this drug plays a role in the prevention of osteoporosis in hyperthyroid patients?
As we know, the beta blocker act on the sympathetic system. However, the sympathetic system per se is a major cause of derangement on the bone. So that those patients with the sympathetic pseudox dystrophy, or nowadays it's called local regional syndrome, they're usually associated with local osteoporosis. And they have studied some of the beta blocker and their association with the osteoporosis. There is a small difference between these beta blocker, in that the new generation selective metoprolol, lateral, has less effect or protective effect on bone in comparison to the old generation beta blocker like propranolol. However, this is little that is written on that subject, and there should be more literature are writing so we can conclude. However, definitely, sympathetic system affection is usually affect the bone as well as the hyperthyroidism.
Thank you very much. And the third question goes to our surgical colleague, Dr. Muhammad Al-Falasi. It says, is finding bilateral adenoma on imaging means double adenoma, or could that be bilateral adrenal hyperplasia of the gland requiring 2/3 removal of it? Dr. Muhammad Al-Falasi.
No, I need the help of a friend.
I like that. Yeah,
Who can be afraid, please? Feel free to answer.
Yeah, it could be by double adenoma. So if it's positive on the scan, both of them needs to be removed. So double adenomas are there. Yes, it can be. As I mentioned, up to 20% can be double. And if it's identified in the scanning, need to be removed.
Actually, during the surgery, we remove the adenoma. We do a rapid PTH. If the rapid PTH drops in between the first sample and the second sample, we're done. But if the rapid PTH did not drop after removing the first adenoma, or the drop was very slight, then I have two options. To question my diagnosis, or wait for a third sample, or go and explore the neck on the opposite side.
No, the question, if you find two adenomas in scanning, you will not go and remove the two adenomas? So positive scan.
Positive scan. And the two adenomas are present, I will remove both of them. But I'm gonna do I'd like to see the ultrasound feature of the adenoma and the size of the parathyroid. I'll start with the bigger one.
Now, there have been some studies saying that, as probably the question, if I understand it correctly, double adenoma, the risk of having actually 4-gland hyperplasia is higher. And some of these patients will show the other hyper secretion of parathyroid hormone from the other remaining two with time. And I have a patient like that actually that we follow in the clinic. So double adenoma removed, and after a couple of months came back again with high PTH and hypercalcemia. So probably she had 4-gland hyperplasia. For reason or another, the scan picked only the two and is not totally negative. Yes.
I would tend to think that it's either a primary hyperthyroidism caused by a primary adenoma, or it's a 4-gland disease.
Yeah, it can be either.
Okay. Question number 4 is someone is thanking the speakers and saying that in the with this notion that there is osteoporosis in hyperthyroid patients, should we follow up the patients with hyperthyroidism with DEXA scan? And if we do, how frequent? Dr. Hussein Noir.
Okay, for the hyperthyroidism, if we look to the guideline, the only mention of DEXA scan in patients with thyroid disease in those patients with subclinical hyperthyroidism, when the TSH between 0.1 and 0.4, and we look for a compelling indication to start anti-thyroid therapy, there is a rule for DEXA scan. However, a common practice, because it is not usually written in the guideline, if a patient has developed a fracture while on thyroid hormone, we should check baseline DEXA scan. If I continue my patient for a prolonged period, he have 2 or 3 relapses on thyroid drug, I will do DEXA scan baseline. Because we have no common practice and no consensus guideline where to do DEXA scan in patients with thyroid disease. This is not mentioned in the guidelines. It's common practice that it's affect the bone. If your patient has high risk of bone disease and fracture, you should check your baseline DEXA scan.
Okay, this question is for Dr. Yusuf. Someone says we see cases that there is no adenoma can be detected radiologically, and surgeons refuse to do surgery, although biochemically there is clear primary hyperparathyroidism. How do you do the sequence of localization if one is negative?
So probably Dr. Muhammad can answer us why surgeons refuse to go in and try to palpate the abnormal glands and help us in removing it if it's abnormal. They said the finger of an high volume surgeon and somebody who specializes in this is probably better than any localization modality. So you try to do it with the system. Maybe it's negative, you go for F18 choline. If negative, then they have the option for MRI. If you're in a research center, high dose of centers that in the state or Europe who do immunofluorescence studies. Again, it's a very research stage sort of radiological testing. You go for these. If not, then try to convince one of the surgeons to go ahead, try to palpate the abnormal glands, if not to resect subtotal parathyroidectomy, remove the majority, leave half of the gland or one gland behind. Re-implantation in the arm, I'm not sure if Dr. Muhammad can answer us in that. If you still practice removing the fore, re-implant one of them in the forehand to make it more accessible in case they have recurrence of hyperplasia. But again, you go with multiple modalities, try to localize. If negative and the patient is significantly hypercalcemic, then there is no other option apart from doing a subtotal parathyroidectomy.
Okay. Next question is mineral metabolism. It seems, is it useful? Maybe Dr. Hussein Noir, I think. Is it useful to supply the patient with hyperthyroidism by vitamin D and calcium routinely?
Sure. Should at least the patient have 1,200 milligram of calcium and 800 international unit of vitamin D. This is a common practice to supply our patient, especially if the patient is postmenopausal. Should take their normal vitamin D and calcium supplement.
Okay.
Ahmed, still, can I hear the opinion of Dr. Falassi on the previous question? What do you do with the negative scan? Multiple modalities of localization are negative. Then, as a surgeon, what do you do?
Yeah. So I will discuss with the endocrinology the indication of the surgery. So if the patient, is he symptomatic? This is my first question.
He is symptomatic, significant hypercalcemia, severe, 3 and above.
There is no other causes causing the hypercalcemia.
Yeah, everything is negative.
Okay, this is the first thing. You have to make sure that there are no other things causing the hypercalcemia. Vitamin D is normal, everything is normal, and it is for sure a primary hyperparathyroidism. So I'll definitely go and explore.
Mm-hmm.
But given the fact to the patient that I might not find the parathyroid, given the fact that exploring the 4 glands and removing the three glands and leaving half, assuming that it's a hyperplasia, removing the 3/4 would treat the problem. But definitely we are in a very difficult situation in this case, and it should be discussed with the patient, the pros and cons. But if the patient, and plus I might ask for another modality of radiology, the 4D CT scan, and try to localize the parathyroid by ultrasound. If it's not fine, scintigraphy. If it's not fine, PET choline. If not fine, 4D CT scan.
An MRI.
And MRI. We have to really explore the different ways. It might be a parathyroid that is in the mediastinum. We had a case like this, and we are all focused on the neck. So involve the thoracic surgery team on board to make sure that the parathyroid is not a mediastinal localized parathyroid. And then weigh the benefit and risk. The other question of the other remark that Dr. Youssef made about re-implanting the parathyroid in the arms, I don't do that anymore. It's because of multiple reasons. One of the reasons is the metaplasia of the parathyroid and changing into malignancy or spreading and not able to removing the parathyroid. I usually remove part of the parathyroid and put a clip on it. Yeah. And to localize the parathyroid if I need to go back in the same area where the clip and remove more from the parathyroid. Or if I'm gonna re-implant the parathyroid, I re-implant it in the sternocleidomastoid muscle. So it's the same wound. I just keep it superficial on the sternocleidomastoid muscle if I need to re-implant it. So it is a difficult scenario. Luckily, it is very rare.
Okay, back to you, Dr. Yusuf. Do you do 24 hours urinary calcium in real practice to differentiate between primary hyperparathyroid versus familial hypocalciuric hypercalcemia?
Thank you for the question. That's a beautiful question. Yes, absolutely. In National Guard Riyadh, it's a must. We do 24 urine calcium on almost every patient. We do that routinely. Today, cases that we've seen, all of them had 24 urine calcium. We don't want to miss FHH. So patients with hyperpara, usually they have hypercalciuria. Those patients with FHH, they have hypocalciuria, low calcium in the urine, which goes against the high blood calcium. So if you have hypercalcemia, you must have hypercalciuria. Primary hyperpara. Then familial hypocalciuric, they have low calcium in the urine, 24 urine collection. And we have few patients who were diagnosed as such.
But I can intervene here by a similar question. If we have normal calcemic hyperparathyroidism, I don't think normal calcemic hyperparathyroidism should have an increased urinary calcium, because the urinary calcium is... Sorry?
Yeah, I'm talking about clear primary hyperpara.
Oh, primary, not the normal calcemic.
Yeah. The normal calcemic, as I put in the schedule, the table that I showed, they have normal 24-hour urine calcium. Yeah. It's not low. And it's not hypercalciuria. They have normal 24-hour urine calcium.
These are the normal calcemic.
Yes, normal calcemic. If they develop hypercalciuria, then they enter into symptomatic normal calcemic hyperpara, and that might be an indication for surgery if they develop hypercalciuria.
Okay. Okay. If a biliary thyroid cancer regrows or recurs after 2 times surgery and radioactive iodine therapy, what is next?
How big?
Dr. Muhammad.
Size. What's the size? And
I don't think he's giving us a scenario. Let's presume the size is more than 2 centimeters. A macro one, not a micro.
I'll give it in 2 scenarios.
Yes, please.
So a patient who had surgery twice. And recurrence of tumor. If it is a microscopic recurrence, okay, microscopic recurrence means opening the neck, you will not find, you will not differentiate between fibrosis and tumor. So opening the neck has higher risk than benefit. You will not be able to identify the tumor and remove it. If the patient have a macroscopic recurrence or residual tumor, then you have to go in and remove it and clear it.
Have a scenario.
Okay, so if the patient have a micro residual tumor, I would follow the patient, keep a very close eye on the patient. And I have a scenario like this for a patient I operated on, that I removed the tumor, a lady, and there was 4 millimeter residual tissue on the recurrent laryngeal nerve. So it grew to 4 or 5 millimeter, not more. She took radioactive iodine, still the lesion. How do we know the lesion? We took an FNA from it. Allah يسامح endocrinology that sent her for the FNA. Okay, so he took an FNA and it's positive. So then we have to follow up her. So I've been following up this patient for the past now 2 years. This small recurrence, which is 5 millimeter, did not grow in size. I see her, Al-Hammadi. I tell her, Madam Al-Hammadi, you are doing fine. I'll see you again. I'll repeat the ultrasound in again 6 months. So, and if there is no growth of the tumor, there is no need to go back and remove this micro residual tumor. But if there is growth of the tumor and the patient has a macro tissue in there, then I have to go back and remove the tumor.
Okay. Right. The coming questions, I think you have to bear with me. Sounds like a long scenario, so everybody can pick his own part of it. A 40-year-old female patient with history of total thyroidectomy due to papillary thyroid cancer, followed by radioactive iodine 2 years ago. Now she presented with cervical, most likely it says LAP, most likely lymphadenopathy. She is now on thyroxine therapy. Please, your kind opinion about further management or just follow up?
No, lymph node metastasis recurrence, FNA proven, you have to go for a neck dissection.
Okay.
Yeah.
So he says now, in continuation to this, now ultrasound showed left neck cervical lymphadenopathy, and the largest one was 9 by 5 millimeters with loss of hilum. TSH was 1.0, antithyroglobulin was 109, while the thyroglobulin was 0.4. That was an antithyroglobulin 109. The thyroglobulin itself was 0.4. He doesn't give us normal range, but I think we are all acquainted with what are the normal ranges. Is that clear? Is it going to you again, Mohammed?
The patient, she had total thyroidectomy only?
Yeah, that's what has been said. And the patient, okay, we still have time. 40-year-old female patient with history of total thyroidectomy due to papillary thyroid cancer, followed by radioactive iodine 2 years ago, now presented with cervical lymphadenopathy. She is now on thyroxine therapy. What, please, your kind opinion about further management or just follow up? Does she need intervention or shall we just monitor her and follow up? And he said, maybe in one of the visits, her ultrasound showed left neck cervical lymph nodes, and the largest was 9 by 5 millimeters, less than a centimeter, with loss of hilum. Her TSH was 1, antithyroglobulin was 109, while the thyroglobulin was 0.4.
Okay, left lymph node, Dr. Ahmed.
Yes.
So left lymph node, 9 millimeter. If the patient is in front of me, she had a thyroid surgery and it's 9 millimeter. If the recurrence is in the central compartment of the thyroid, 9 millimeter, I will wait. I will not go because opening an already opened wound with lots of adherence and fibrosis, most likely, how good the surgeon is, it will be difficult to remove this lymph node if it was in the central compartment, because he did not specify, or he left side central or lateral compartment.
He said lateral.
Yeah, he said lateral.
No. If the patient is on the lateral compartment, I would extend the wound and I will do a full neck dissection of level 2, 3, 4, and 5B.
What about FNA before you go for dissection?
Yeah, for sure. FNA
first.
First FNA, for sure. Yeah. This is no question about it. FNA, if it is proven and it is mapped on which level, I will focus on that level, but I will remove all the lymph nodes at level 2, 3, 4, and 5B.
Dr. Ahmed, so she has positive antibodies. So this patient, the thyroglobulin cannot be used as a tumor marker.
It can be excluded, yes. It has no value.
You go for FNA and then you decide about with the surgeon about the lymph node dissection.
Right. This guy seems to be a surgeon, this guy. He says, he continues to say, if the decision is to do central and lateral neck dissection, do you have a reason for bilateral or unilateral neck dissection? Do you get this, Ahmed?
Yeah. if the ultrasound shows unilateral disease, radiologically unilateral disease, there is no need to go for a bilateral prophylactic neck dissection. But
there is no need.
If the patient shows only a unilateral disease, but if in radiology it shows that it is bilateral lymphadenopathy, I'll take FNA from that side and from that side. If the other side is benign, I won't touch it. I'll go for only one side.
Okay. There's a difficult question. I'll try to read this one. What are the sensitivity and specificity of systemic scan in detecting? This is for Muhammad. I think this is for Yusuf. What is the sensitivity and specificity of systemic scan in detecting parathyroid adenomas, and what about intraoperative parathyroid measurements?
The intraoperative, I talked about it, and Dr. Muhammad also mentioned it. So you do samples at 0 before surgery, and then at 5-15 minutes, and you see the drop, 50% drop in PTH level after successful removal of parathyroid adenoma. The sensitivity and specificity, I cannot remember the figures exactly, but they are in the 90% range. So it's quite good, picks up majority of patients, and good sensitivity and specificity.
But Dr. Muhammad, do you ever need to do intraoperative parathyroid assessment or assay by going into the, say, jugular vein or something, to make sure you have left something behind? Do you ever need to do that?
I don't.
Intraoperatively taking sample for parathyroid hormone assay?
When I started operating, I used to do it. But currently, if there is a parathyroid adenoma and it is localized by ultrasound and scintigraphy, and it's a very clear parathyroid. I mean, when we remove the parathyroid and it is an adenoma, it's very clear. I send it for pathology, frozen section. I need two things from the frozen section. One, the size of the parathyroid. Two, the weight. If they tell me that the weight is
50 grams.
It's 10 times or 20 times more than the normal weight, and the size is bigger, I will not do a parathyroid hormone assay, and I will not. I'm sure 100%. I mean, it's experience based. It's not my ego speaking; it's my experience. So I would bet that this is a parathyroid adenoma removed. But if I have a doubt, and it's a difficult scenario like the case that we discussed with Dr. Yusuf earlier, with the 2 parathyroid adenomas or hyperplasia, if there is any challenges, it's not a straightforward case, I would go for a parathyroid assay. But if it is very clear, it is very clear and localized, I would stop there just by a frozen section.
Okay, I think this seems to have concluded our questions and our time. And I would like here to thank all those who participated in this activity. Thanks to you. And back to Dr. Thamer, do you have anything to say, please?
Enjoyed the presentations, the discussion, very fruitful, very well done. Thank you so much for all the participation. Thank you, Dr. Ahmed, also.
Thank you all. It's just the exact timing. I don't know why you're doing so far.
Very impressive.
Everyone has finished on time, so did we. Thank you all.
Thank you.
Have a good night.
Assalamu alaikum.
Thank you so much. Have a good night.